Hey everyone, how are you all? So how are these classes going on? You had few classes with us so far. So you had trial session where we discussed about the AMC introduction of how the AMC MCQ works. You had sessions with me about tips and tricks of question solve sessions. And then we had a cardiology class on chest pain very recently. And also you had yesterday, you had a class on random question solves, which are basically some of the questions that is important for your exam. Okay. And today we're doing cardiology theory 2. So we try to finish as much as possible in these two classes. But again, cardiology is quite vast. We will not be able to finish everything in these two classes. You will still have your ECG class with palpitation chapter, but that will be part of the course student, not as a free trial sessions. Once we finish these free classes, we will start in full rhythm and we will finish cardiology at that time. All right. And you'll find out that now you know that how we incorporate two things at a time. We do these theory sessions and improve your knowledge, improve your idea about the important theory topics, and then you also get to know about the random questions. Random questions open up your brain. It's just brainstorming that because it can come from anywhere, and it shows how in exam you can be challenged and how in exam the questions are going to appear, because there will be no specific topic from where exam questions will come. It will come from anywhere. So we try our best to give you that experience in these random recall sessions where you get to know like important topics, important questions, and how questions can be challenging in exam, and how to come to the right answer in the exam. That's the plan, and it works really, really good. It has been worked out forever. So far, we have achieved brilliant results with this strategy, and the students who are part of this course, we always find that initially the random questions are challenging. It's difficult, and I get that because you're still uh, you don't know a lot of things at the moment, and that is normal, and everyone felt the same. But as I said last time also, once you start finishing some of the theories, once you start knowing things, it will start making sense. So don't feel overwhelmed, don't feel pressured. Remember one thing, that if you knew everything, you would go for exam right now, because you don't know anything. That's why you're starting, and it is learning process, and it takes time. You just need to give the time, right? It's the medical science is like that. If you give time, if you can sacrifice some of the time, you can pass any exam. So it's all about how much hard work, how much strategic you are, how smart you read, and knowing things, having your eyes and ears open. That's all that matters. Okay. So let's start. Yes, random question solve session will be uploaded. Today we are doing cardiology theory session. We will start with heart failure. Let's have a look how heart works basically. So basically, like, the cardiac function is about pumping. So when heart cannot pump blood, that is the time we develop heart failure. So there is a lot of things to learn from here. Now, this video is not that great, but it's just like a start of how the pumping action works. I know you are not able to get the audio of it. Let's not bother about it. I'm going to give you a very good idea about cardiac pathology and how the heart failure and everything works. And I'm sure you will learn a little bit better than you have learned before. So knowing the pathophysiology of cardiac system is the first thing, because if you don't know the cardiac pathology, then you actually can't understand whatever we are going to talk today. So I'm going to take some time to go back and understand the cardiac anatomy and pathophysiology, okay? And I'm sure like a lot of you know that, but let's just recapitulate. So we've got your heart. We know heart has 4 chambers. So we have got our right atrium, we've got right ventricle, we've got left atrium and left ventricle here, right? And then so right atrium gets blood from everywhere in the body. So superior vena cava will carry blood from upper extremity and head and neck, and it will carry all the deoxygenated blood, which is the carbon dioxide blood, into the right heart. So you've got your superior vena cava, and then inferior vena cava will carry all the deoxygenated blood from the lower extremities. So from hepatic vein, portal vein, and also from the lower extremities, all the blood will come through the inferior vena cava into the right atrium, right? So all the deoxygenated blood from everywhere in the body coming into the right atrium from SVC and IVC. And then from the right atrium, the blood goes into the right ventricle, and we have got a valve here, which is our tricuspid valve. From right ventricle, blood then goes into the lungs through the pulmonary artery. So if this is our pulmonary artery, and we have got our pulmonary vein here, right? So from right ventricle, blood will then go through the pulmonary vein, pulmonary valve, into the pulmonary artery, and then it goes to the lungs, right? So this is the journey of the deoxygenated blood. So again, all the deoxygenated blood coming into the right atrium and then goes to the right ventricle, and through the right ventricle will pump the blood through the pulmonary artery into the lungs. In the lungs, this deoxygenated blood, so still now these are all deoxygenated blood, will get oxygenated. Okay? What happens is there, so what happens in the lungs, so we know that we have got the alveoli, so which are all the small air sacs in the lung. And then we have got these capillaries, the blood vessels around it. So when we take a deep breath, which is when we take a deep breath in, we are taking oxygen into our lungs. So then oxygen will reach to this alveoli, and let's say that this is our alveolar capillary membrane, through which there will be diffusion or exchange of gas. So through this alveolar capillary membrane, now see that this pulmonary artery, it becomes smaller and smaller, and it becomes capillaries at the end, right? So these capillaries are carrying carbon dioxide. So this carbon dioxide will then diffuse into the alveoli, and then you will exhale the carbon dioxide out of your body, and this oxygen will then come into the artery or into the capillary. So this is our gas exchange that's happening in the lungs. So in the lung, carbon dioxide will get out of the system and oxygen will go into the body. Now this oxygenated blood then will be carried by pulmonary vein. So the pulmonary vein will carry the oxygenated blood into the left atrium. From left atrium, blood will then go to left ventricle, and that's our mitral valve. And then from left ventricle, blood will then go to the aorta, right? And then we have got our aortic valve. So again, I know this is where you lost me. So there is gaseous exchange between oxygen and carbon dioxide. Oxygen is going in, and then the oxygenated blood will be carried by pulmonary vein into the left atrium. Through the left atrium, it goes to left ventricle. We have got mitral valve in between these two. And then through the aortic valve, blood will then be pushed to the aorta, and through aorta, it goes to the rest of the body. Okay, so that's our main basic. We should all know that. If we don't know this, we really don't understand cardiac. Now, the problem happens, let's say that heart, the left ventricle, the main function of left ventricle, that it, every time there is a systole means contraction of the heart, and diastole means relaxation of the heart. And heart does this. So heart contracts, and when it contracts, it pushes all the blood into the aorta, and it goes to the body. And then it relaxes, which is the diastole, and during diastole, it relaxes. And when it relaxes, it takes all the blood from the vena cava into the right atrium. Okay, so during systole, heart will push out the blood. During diastole, heart will take all the blood inside so that it can push out again. That's the systole and diastole of the heart. If a patient's having problem in either one of them, either systole or diastole, that is the time the patient can develop features of heart failure. The commonest heart failure is related to systolic problem, which means the heart is not able to pump enough blood to the body. So let's say someone has got cardiac infarction or myocardial infarction. So due to myocardial infarction, there is massive necrosis of the left ventricular muscle. So the left ventricle becomes weak, and when it's weak, it cannot pump enough blood. So when it cannot pump enough blood, if heart is not able to pump enough blood, then the body is not getting enough blood supply as well. The problem is that when it can't pump, there is some residual blood volume staying in the heart. So the problem appears that in patients who cannot pump enough blood, there is backflow. So the backflow means that, let's see, so heart is supposed to pump blood into the aorta, but heart is not able to pump at the moment. So there is already a lot of blood accumulating in here. So then what will happen, that every time heart is getting filled up, right? So there is backflow now. So the blood is now going back, and it's getting accumulated in the left atrium. And when left atrium gets full, then it starts giving more backflow. So let's say that left atrium is now full. So it gives more backflow, and blood or fluid starts to accumulate in the lung. Are you guys getting me? So let's say that a patient who is having heart failure, definitely he's not pumping enough blood. So there is overflow in this chamber. When this chamber is full, definitely blood will not be able to come in this chamber anymore. So it will stay here. So there will be overflow in the left atrium. And then at one point, there will be overflow in the pulmonary vein. And then back to the lungs. And when there is more fluid accumulation in the lung, that is the time patient will develop pulmonary edema. And that is the time patient will feel that they have difficulty in breathing when they're lying down. That's what we call orthopnea, because now their lung is full of fluid. And when they're lying down, the fluid starts to come all into the lung because of the gravity, and patient starts to feel short of breath. At some point, the lung will be full. So then it starts putting pressure in the pulmonary artery. That's the time patient will develop pulmonary arterial hypertension. It's not backflow. It's like overloading. Okay, so if this chamber is full, the fluid cannot go into this chamber. So it starts to become overflow. Okay, it's not like backflow because it is functioning heart valve. So because the left ventricle is now full of fluid and blood, definitely blood cannot come into the left ventricle, so it starts accumulating in the left atrium in that way. So it just goes, it becomes overloaded one by one. Now, because of pulmonary arterial hypertension, have a look over here. Now, right heart needs to push blood against this high pressure in the pulmonary artery. Now that pulmonary artery has got high pressure, right ventricle needs to push harder to send blood into the lungs. So what happens that right ventricle starts to become hypertrophied because now it is working hard to send all the blood into the pulmonary artery. That's the time the right heart will develop right ventricular hypertrophy. As always, when something works harder and harder, at some point, it loses its elasticity and it fails. So at one point, right ventricle will not be able to push blood into the pulmonary artery. So the right ventricle will become overflowed. When right ventricle is overflowing, right atrium will also starts to become overflow. Now the problem is now there is more and more blood accumulated in the right atrium. But we know that from all the extremities, blood is coming into the right atrium. Now it can't because it's already full. If it is full, then blood cannot come from the extremities anymore. So that is the time in the neck, because this is now getting overflowed, superior vena cava, you get raised JVP. So distended neck veins. Then, because the portal vein carries all the blood through the inferior vena cava into the right heart. So now there is hepatic congestion because blood from liver is not coming into this right heart anymore. So due to hepatic congestion, you get tender hepatomegaly. And then because inferior vena cava is not carrying the blood from the lower extremities, lower extremity now gets swollen, causing ankle edema or pedal edema. So basically, it is the left heart failure which eventually causes right heart failure, and that's what we call congestive cardiac failure. Okay? Did it make sense, everyone? I tried to make it as slow as possible, but this is how it works. Yes, isolated right heart failure can occur, but that's most of the time due to lung causes, which is what we call cor pulmonale. Everyone good? No questions about this? All right, very good. So now that you understand this basic, we can move forward. So today we are starting with congestive cardiac failure or heart failure. So in a patient who gets heart failure, what are their presentation? So heart failure patient, they will definitely come to you with shortness of breath. They may even say there is shortness of breath on exertion. So when they walk, go for a run or exercise, they feel the shortness of breath get worse. And they can also complain orthopnea, especially for pulmonary edema patient, they will get orthopnea, which means they get shortness of breath when they lie down. These patients can also have a dry, irritating cough at night. They get quite fatigued and lethargic because there is fluid accumulation. They can say that I'm gaining a lot of weight, ankle edema, and due to hepatic congestion, they have abdominal discomfort can also happen. They can also have dizziness, spells, weakness, fatigue because of reduced cardiac output. So the main feature of heart failure is shortness of breath on exertion, and fatigue, weakness, dizziness. That's usually the main presentation. We already know that left heart failure usually presents with pulmonary edema, right? So if the main presentation is pulmonary edema, we get bibasilar crepitation. So on examination of left heart failure, we will get bibasal crepitation. We can get third heart sound, which is called gallop rhythm, and few others like tachycardia, tachypnea that can be there. But this is our main presentation, bibasal crepitation. For right heart failure, we already know that they will have raised JVP, ankle edema, and tender hepatomegaly. Heart failure, we divide into many subtypes. So we have got right heart failure, left heart failure. We have got systolic failure, diastolic heart failure. We have got heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. Just a fancy name for systolic and diastolic. So let's talk about systolic and diastolic failure. As we mentioned already, that systolic heart failure is the classic heart failure, and that is due to abnormal pumping of the blood from the left ventricle into the rest of the body. So it's mainly inadequate pumping action of the heart. So basically, in this case, the left ventricle is not contracting properly, and if it is not contracting properly, it's not sending enough blood to the rest of the body. Now, this pumping action, the contraction of the heart, is directly related to ejection fraction of the heart. So as you know that ejection fraction depends on the cardiac output. So in systolic heart failure, we know that cardiac output is reduced. So if cardiac output is reduced, ejection fraction will be also reduced. In a normal person, ejection fraction should be between 45 to 65%. And in case of systolic heart failure, you will find out that their ejection fraction will be less than 45. So that's systolic heart failure. Diastolic heart failure is when the heart is not relaxing properly. So if heart doesn't relax properly, it cannot take enough blood from the extremities. So if the heart is stiff, then heart cannot take blood from the upper and lower extremities. So we know that heart needs to relax so that it has a space for all the bloods to come in. So diastolic heart failure is heart failure when heart is unable to relax properly, which means problem is in the ventricular filling. The pumping action is fine. So in these patients, ejection fraction will be normal. That's why we call it heart failure with preserved ejection fraction. And that's why the systolic heart failure is called heart failure with reduced ejection fraction. Okay? Causes of heart failure. Systolic heart failure, the main cause will be ischemic heart disease. So if someone has got ischemic heart disease, MI, That's the most common cause of systolic heart failure. Hypertension can be one of the other cause. And diastolic heart failure, usually similar kind of cause, like ischemic heart disease, hypertension, aortic stenosis, hypertrophic cardiomyopathy, all of these can cause diastolic heart failure. So we know now about types of heart failure. We know what are the symptoms of heart failure, what are the physical examination findings of heart failure. So if we get a patient with possible heart failure, what's going to be our initial investigation and what's going to be our confirmatory investigation? What do you think? So initial investigation is always going to be ECG. Remember that. Even we know that ECG might not give us enough information of heart failure, but still you would never do echocardiogram in a patient without doing a simple ECG on the bedside. So heart failure patient, your initial investigation will be ECG. Your confirmatory or best investigation will be echocardiogram. And echo can confirm, one, that is it a heart failure, and two, it can say whether it is a systolic or diastolic heart failure, because echo can mention whether there is reduced ejection fraction or normal ejection fraction. Apart from electrocardiogram or ECG or echo, we can also do a chest X-ray. We know that in systolic heart failure patient, we can get cardiomegaly. And sometimes in pulmonary edema, we get some other findings. We'll talk about it. There is another thing called BNP, B-type natriuretic peptide. BNP, it's a hormone secreted by ventricular myocardium. A lot of people think that BNP is a diagnostic investigation. It's not a diagnostic investigation. We do not do BNP to diagnose heart failure. We do BNP to monitor the severity of heart failure or progression of the heart failure. Now, yes, if by any chance you are working in a rural area and you don't have any access to echocardiogram, you can do BNP in that case, because yes, in heart failure patient, it will be elevated. But as a general rule, we don't do BNP to diagnose heart failure, okay? Cool. Investigations done. So now that you know that what kind of heart failure it is, you need to manage the patient. So all patient with heart failure with reduced ejection fraction, so that's the systolic heart failure, right? All of them has to be started with 4 medication altogether. So there are 4 medications that we start in this patient right away. What are those 4 medications? So you have got ACE inhibitor or ARNI. So we'll talk about ARNI later on. We have got heart failure specific or cardioprotective beta blocker like atenolol, metoprolol. We have got MRA, so mineralocorticoid receptor agonist, and SGLT2 inhibitor, which is your empagliflozin, dapagliflozin, those ones. And MRA is the spironolactone or eplerenone. So these 4 medications are the basic medications every heart failure patient should be on. Except beta blocker, we will not use beta blocker in a patient who is in uncontrolled heart failure or poorly controlled heart failure. Meaning that if someone having congestion at the moment, like you can see that they have got all edematous and all, that means fluid overload. So if your patient is having fluid overload or heart failure is not well controlled, then you will not start beta blocker until the patient becomes euvolemic. So once edema and all the fluid congestion is over and you have treated them, then you can start the beta blocker. Okay, why is that? Because beta blocker is gonna reduce the heart rate. and the systolic heart failure patient at the moment already is struggling to pump the blood. So we don't want to start a medication which is gonna reduce the heart rate and reduce the contraction capacity of the heart. Okay, but eventually when the patients become stabilized, then this beta blocker is really helpful because the heart always tries its best to pump blood, and it works, like it does overwork, and then the heart muscle becomes remodeled, it becomes hypertrophied, failed, and all. So to prevent that, beta blocker works really good. Okay, and it calms down the heart, and it has survival benefit for heart failure patient. This is a very good medication, but not during the fluid overload status. When the patient is euvolemic, then we can start it. So you can see here, if it is a congested patient, you start every medication except once the patient becomes euvolemic, you start the beta blocker. If it is a euvolemic patient, you can start all the medications together. And then you gradually increase the dose until you get into the target dose, and also patient becomes completely stable. Okay. Now, let's say you started the patient with ACE inhibitor. So you know ACE inhibitor is your ramipril, captopril, right? So this ACE inhibitor, let's say you started with ACE inhibitor, and you are increasing the dose gradually to a maximum target dose. And you usually do that within 3 months. So after 3 months, you do a repeat echocardiogram. And if you find out after 3 months that the patient's ejection fraction is still less than 40, even after 3 months of trying these medications, then you change the ACE inhibitor to ARNI. Okay? That is the guideline from, so we use the therapeutic guideline for this whole heart failure things. The John Murtagh or any other guideline, they are not updated enough for this. So you will be following this flow chart for heart failure treatment. Now, let me show you a little bit from therapeutic guideline. Just one second. Okay. So we already talked a lot from here anyway. So start all the 4 classes of drugs at diagnosis, or at least within 2 to 4 weeks of diagnosis, and optimize the dose. We took the flow chart from here, as you can see. So as you can see here that we can initially start with ACE inhibitor, which is the angiotensin converting enzyme inhibitors, or angiotensin 2 receptor blocker, which is the ARB. So either ACE inhibitor or ARB we can start with. And then we have the option of changing the ACE or ARB to this ARNI. ARNI is angiotensin receptor neprilysin inhibitor. Okay, so ARNI is a combination of sacubitril and valsartan. So that's why if you start the patient with ARNI, you cannot give ACE inhibitor or ARB because the ARNI has valsartan in it. So how sacubitril works? So sacubitril is a combination, as you can see, it's a part of ARNI, it blocks this neprilysin. So that's why we call it neprilysin inhibitor. So it blocks this enzyme, and by blocking this enzyme, it saves some of the natural peptides in the blood vessels, which relax the blood vessel. Okay? So when we inhibit the neprilysin, it helps to save those natural peptides, which can relax our blood vessels, and relaxing the blood vessels are important. Otherwise, patient will have high blood pressure. And also, it helps our body to get rid of extra salt and water. Okay, so this neprilysin is not a good enzyme. We need to block that enzyme. So when we can block this enzyme, we can relax our blood vessels, and also we can get rid of excess salt and water from the body, which is helpful for high blood pressure and also heart failure patients. Because excess salt and water is definitely not going to help this patient. This patient already is having fluid accumulation. We want something that can reduce the water, and we don't want extra salt. We want to get rid of the salt because salt can increase fluid volume, right? So that's how this ARNI works. Can we start ARNI initially instead of starting ACE or ARB? What is the indication of that? We can do that if we find out that patient's ejection fraction less than 30%. In that case, we don't need to start the patient with ACE inhibitor or ARB. We can directly start with ARNI. But when it is between 30 to 45, in that case, we can start with ACE or ARB first, and then wait for 3 to 6 months and see if the ejection fraction improves. If it doesn't improve more than 40, then we can introduce ARNI. So all of you know about ACE inhibitors, so captopril, enalapril, just know some of the name. You don't need to know the dose of it. You know about the ARB, candesartan, irbesartan, telmisartan, valsartan. These are all ARB. Very commonly, one question comes in exam, and it's very common in a lot of patients, that ACE inhibitors can cause chronic cough in a patient. So if a patient is on ACE inhibitor and then they're having chronic cough, you need to change the ACE inhibitor to ARB. Most of the time, you will find out that it really helps. The second thing is that ACE inhibitor is very well known to cause angioedema. And it might not happen even within a day or two of taking the medication. Sometimes years and years later, patient can develop ACE inhibitor-induced angioedema, which is swelling of the lips and tongue. Not anaphylaxis, but swelling of the lips and tongue can happen. So in that case, again, you need to change the medication to something else, like ARBs. The beta blocker for heart failure, so bisoprolol is very commonly used, carvedilol, metoprolol, and nebivolol. These are common beta blocker that we use for heart failure. Then we have MRA, which is the mineralocorticoid receptor antagonist. So you can use spironolactone or eplerenone. You need to just know the name of the medication. You don't need to know the dose of the medication. And the fourth medication, which is very, very important, is SGLT2 inhibitor. SGLT2 inhibitor is, we use it for diabetic patient, right? But it also helps with heart failure patient with reduced ejection fraction. Now, how it really helps, it's not well understood, but they're saying that it helps with cardiac remodeling. So SGLT2 inhibitor is dapagliflozin or empagliflozin. So this will be also started in this patient. Cool. So these are the 4 medications that we are going to use in all heart failure patients who basically have systolic heart failure. Few other medications for heart failure patients. One, that if heart failure patient having congestion, fluid overload, That is the only time we use the loop diuretics, which is your furosemide or bumetanide. There is another medication called ivabradine. Ivabradine, it reduces the sinus rate or heart rate. It reduces cardiovascular death and hospitalization for heart failure in patients who are in sinus rhythm and has heart rate of 70 beat per minute or more, despite taking the maximum dose of beta blocker. So this is only indicated that you're giving beta blocker to the patient and you went to maximum tolerated dose of that, but still the patient's heart rate is staying more than 70. That's the time ivabradine is indicated, because we want to bring the heart rate low, okay? That's mainly all you really need to know for heart failure medications. I hope it made sense, guys. NYHA classification is not that important. In heart failure patient, we can tolerate low blood pressure even up to 90. Okay? So even at 90, we are fine. As long as they are not dizzy or lightheaded, we are fine. We want to keep the blood pressure low, Tatiana. Okay? So, but again, if they are having symptomatic dizziness, they're about to fall, then yes, you need to reduce the dose of these medications. So that's why we say maximum tolerated dose. You start slow and gradually titrate the dose so that these things doesn't happen. One thing is very important. Just because someone has got mild asthma, beta blocker is not absolutely contraindicated for them. So yes, it should be used carefully, but again, it's not like that just because someone has got mild asthma or who doesn't even take inhaler that we can't give beta blocker for them. And we do not like to use calcium channel blocker in heart failure patients, especially for reduced reduced ejection fraction. CCB is not our ideal medication. Arni is the Entresto in Australia. That's right. The SGLT2 inhibitor has risk of any kind of diabetic medication has risk of hypoglycemia, but SGLT2 inhibitors, mainly it can cause, so because it takes all the glucose through the urine, so patients, especially elderly patient, has risk of glycosuria, which can cause UTI commonly, dehydration, that's common in these patients. So as a summary, the medications that we are going to use for heart failure with reduced ejection fractions are ACE inhibitors, then beta blocker, spironolactone, which is MRA, and SGLT2 inhibitor, which is your dapagliflozin or empagliflozin. Okay. So you can see here, all these 4 medications has mortality benefit for heart failure. So these are all really, really important medications. So ACE inhibitors, beta blocker, spironolactone have been shown to improve survival in congestive cardiac failure patient. Diastolic heart failure or heart failure with preserved ejection fraction. So when that is the case, now in this case, we don't need a medication which is gonna help to contract the heart. All right, so we don't need a medication which is going to contract or which is going to increase the pumping action of the heart. We don't need that. We need the heart to relax and get time to fill up. So what medication can do that? Calcium channel blocker and beta blocker. So for heart failure with preserved ejection fraction, our choice of medication will be calcium channel blocker or beta blocker. Okay? So that's all about this part of the heart failure. We know about congestive cardiac failure now. Okay, some of the medications. So although pharmacology is not a topic in AMC MCQ, pharmacology related questions comes in exam a lot. Okay, so you need to know the common medications side effects or complications. So any medications which are commonly used, you need to know their common side effects. So have a look in here. Thiazide diuretics, which is hydrochlorothiazide. The common complications are hyponatremia, hypokalemia, hypercalcemia, hyperuricemia. So a gout patient, if you give thiazide diuretics, you can cause flare-up of the gout. It can also cause some impaired glucose intolerance, or it can increase blood sugar. So you should know that it causes hyponatremia, hypokalemia, hypercalcemia, and hyperuricemia. Loop diuretics, which is furosemide, and indapamide has similar side effect like thiazides. Furosemide or bumetanide, the loop diuretics causes everything gets low. So sodium, potassium, calcium, everything is low. They also can cause hyperuricemia, but they have a side effect which is ototoxicity. So it can cause deafness. And then we have got potassium sparing diuretics, which is a spironolactone or eplerenone. That is very commonly asked in exam. So it can cause hyperkalemia and gynecomastia. All right, so please remember these common side effects because this will come in exam in a lot of ways. One of the other thing that previously we used digoxin a lot. Nowadays, digoxin is rarely used because there are so many good medications with less side effects than digoxin. So we no longer use digoxin, and it's like, unless it is absolutely necessary in heart failure patient, it is our one of the last resort, especially if a heart failure patient has got atrial fibrillation and you have tried all the other medication, it's still not working, then sometimes we use digoxin. Why digoxin? We don't like it because it has side effects and it's quite commonly causes a lot of problem. So the side effects of digoxin is it can cause nausea, vomiting, it can cause blurry vision, yellow halo around the eyes, around the objects, and it can cause almost any kind of arrhythmia. So if a patient who is on digoxin and they develop this nausea, vomiting, or yellow halos or blurry vision, you need to stop the medication. And if still, even after stopping the medication, the symptoms doesn't get better, then we can use lidocaine or we have DG bind. So DG bind is an antidote for digoxin toxicity. Not that important, just remember it. There is one thing that sometimes also comes, it's called implantable cardioverter defibrillator, ICD. So ICD is a device, especially it is supposed to prevent death in severe heart failure patient because they can get life-threatening arrhythmia or cardiac arrest. So in a patient who has dilated cardiomyopathy, we will come to the cardiomyopathy after the break. In a patient who has dilated cardiomyopathy and ejection fraction less than 30%, 35%, they are the group of patient who has high risk of death from cardiac arrest. That's why we give them prophylactic ICD, and if they go into cardiac arrest, then this ICD will give them a shock, okay, to come back to the normal rhythm. So that sometimes comes in exam. Pulmonary edema. So you know that pulmonary edema means that the patient has got left heart failure. It is a medical emergency because patient can go into respiratory failure. So in patient with pulmonary edema, definitely they will have increasing shortness of breath. They will have tachypnea, so respiratory rate will be increased, tachycardia. They get orthopnea. They also you'll find out that they will complain. Sometimes they will have cough, which is pink, frothy sputum-like cough. So they will develop this pink, frothy sputum. So in a patient, especially it might be even a known heart failure patient, suddenly coming to you with increasing shortness of breath, not able to lie down because it just makes it worse. And also patient is having increased respiratory rate. Oxygen saturation can go down. Even in this patient, you can get wheezing, okay, which is called cardiac wheeze. So, and then bibasilar crepitation will be there. If you do X-ray, one, that the heart silhouette will be increased, so cardiomegaly will be there, and you can get this bat wing appearance, which these opposites you can see, which is the interstitial opposites on the both side of the lung, and that's what we call bat wing appearance. It means that it's a very severe pulmonary edema. Usually, will give this picture. Okay, and you can see this is the start of the bat wing appearance. You can see all this interstitial marking here. Okay, so that's how pulmonary edema will present. It is a medical emergency because patient goes to respiratory failure quite fast. So your first line treatment will be put the patient in a popped up position and then start the patient with oxygen and then start the patient with diuretics, which is your furosemide, to reduce this excess fluid overload. All right, so that's the initial treatment, and then gradually you will start the patient. When the patient becomes stabilized, you will also start all the heart failure medications in this patient. But the main thing is propped up position, oxygen, and diuretics. That's all about heart failure. Okay, any questions with the heart failure, guys? What about ivabradine? Gina, what do you want to know? Important means that just knowing that ivabradine is an option in a heart failure patient where you have used beta blocker in the maximum tolerated dose, but it's still the heart rate is more than 70. And heart failure in pregnancy, it is not, now you can't use all the medications that we are using here. So you can't use most of the medications. Like beta blocker we can use, it's safe. You can't use any of those ACE inhibitor, ARB, ARNIs. You can't use a spironolactone. And also we try not to use the SGLT2 inhibitors. So almost all of them are contraindicated. So your option will be mainly reducing the fluid overload with diuretics. So diuretics are safe. And also we can use yes, nitrates, hydrolygens. This is fine to use. Yes, oxygen if it is less than 95%. We're moving into valvular heart disease. So valvular heart disease is important for exam, but remembering and memorizing all these heart murmurs can be quite difficult. And there is no good way of memorizing this. It is difficult. So, but still I try my best to show you some good ideas so that you can remember them. Okay, so let's have a look at how valvular heart disease can come in exam. Mainly for valvular heart disease in adult cardiology, the murmurs, different type of murmurs, they just give you a patient and they say that this patient has got this type of murmur. What's your likely diagnosis? That's usually the question that comes in exam. So you know already that we have got 4 heart valves, right? So if we draw the picture here, so we know that we have got tricuspid valve, we have got mitral valve, we have got pulmonary valve, and we have got aortic valve. These are the 4 valves. The main ones that comes in exam is mitral and aortic. Okay, so if you can at least memorize the mitral and aortic valve disorders, that will be enough for exam. In a valve disorder, there are 2 types of valve disorders. Either the valve can become narrow, which is stenosis, or valve can be weak or not functional, and it can cause regurgitation. So it's supposed to be a one-way valve, right? Or one-door valve. So the blood is only supposed to come down, not backflow. So when there is backflow, that means the valve is weak, and that is regurgitation. So we can get mitral stenosis, we can get mitral regurgitation. We can get same aortic stenosis, aortic regurgitation. Remember mitral stenosis murmur, and other 3 you can easily remember by what I'm going to show to you. Before that, first have a look about the site of the murmur. So always remember that so this is the sternum, let's say. So this is second intercostal, third, fourth, fifth, and sixth intercostal. So let's say that's your heart is sitting like this. On the left, so this is the left side, that's the right side. On the left fifth intercostal space, okay, so on the left fifth intercostal space, that's our apex. And in the apex, we get the mitral murmur. So mitral murmur are best heard on the apex, which is the left fifth intercostal space. So let's remember that first. Then the tricuspid murmur. The tricuspid murmur is best heard on the left fourth intercostal space along the sternal edge. So just over here. Then we have aortic murmur and pulmonary murmur. Now, this is where people get a bit confused. Both aortic and pulmonary murmur is heard on the second intercostal space. Now, you might think that aorta, because it's coming from the left, aortic murmur should be heard on the left side. Not actually. So you can see that it goes like this. That's why aortic murmur is best heard on the right second intercostal space. Especially aortic stenosis murmur is best heard on the right second intercostal space. And pulmonary murmur, because pulmonary, it goes like this. So it's best heard on the left second intercostal space. So very important, people confuse this a lot. One exception to this is aortic regurgitation murmur. Aortic regurgitation murmur is best heard on this spot, left fourth intercostal space. All right. So this is important because this helps a lot to come to the right answer in the exam. So you need to remember the site of the murmur and then type of the murmur. So site of the murmur is done. Let's talk about the type of the murmur. There is no chapter in John Murtagh for the valvular heart disease. So we are just discussing it from few topics like RSCGP. We will show you just in a bit. Let's talk about mitral stenosis murmur. Remember one murmur and every other murmur will be easy to remember. So mitral stenosis murmur is what we call mid-diastolic murmur. And now we know it is best heard on the left fifth intercostal space. Think about like this. So we're talking about mitral and aortic. So although opposite of mitral is not aortic, but for the sake of remembering it, remember the opposite of mitral is aortic and opposite of stenosis is regurgitation. So what is the opposite of mitral? Aortic. What is the opposite of stenosis? Regurgitation. So these two murmur is diastolic murmur. So MS is MDM, mid-diastolic murmur, whereas AR, aortic regurgitation, is early diastolic murmur. Okay? Now you can easily get the other two. So what's left from MS? So we have mitral regurgitation and we have aortic stenosis. Because we already got MS, so we left with MR, and we already got AR, so left with AS. Now these two are systolic murmur. So these two are diastolic, so definitely these two are systolic. And it's very easy now to remember. So aortic stenosis is ejection systolic murmur. You can see this E goes with this E. And the mitral regurgitation murmur is pansystolic murmur or hollow systolic murmur. Does it make sense, everyone? Is it easy now a bit? Because you can easily now get it. Like, even if you forget in the exam, I'm sure just by using what I've said, you can come to the right answer. Yeah, let's repeat it a little bit. So mitral, just remember the mitral stenosis. Mitral stenosis murmur is a mid-diastolic murmur. So as I said that for the sake of remembering, remember the opposites. So opposite of mitral is aorta or aortic. Opposite of stenosis is regurgitation. So we remember only the MS. MS is mid-diastolic murmur. So what's the opposite of mitral? Aortic. Opposite of stenosis is regurgitation. So if MS is mid-diastolic murmur, AR is also a diastolic murmur, but it's early diastolic murmur. All right, so we have got the diastolic murmur. And then what's left from mitral and aortic? We already got MS, so MR is left. We already got AR, so AS is left. These two murmur are systolic murmur. AS is an ejection systolic murmur, and MR is a pansystolic murmur. These two murmur also radiates. MR radiates to axilla, and AS radiates to carotid or neck. Yes, aortic regurgitation is left fourth intercostal space. That's the only one which does not follow anything. Everyone clear? Now, there are some murmur where we need to use accentuation maneuver. So accentuation maneuver is sometimes aortic murmur or mitral murmur. You might not be able to hear it properly because it might be low intensity murmur. So if you are concerned and if you find out that, no, I am not getting any murmur in this patient, before you say that murmur is absent, it's important that you do this accentuation maneuver. What is this accentuation maneuver? So for aortic regurgitation murmur and for mitral regurgitation murmur, so these two murmur usually can get accentuated, or you can hear it better if you ask the patient to take a deep breath in, breathe out, and hold. So during expiration, so if you ask the patient to take a deep breath in and then breathe out, which means in expiration, if you listen to the heart valve areas, or if you auscultate, these two murmur can accentuate. Okay, so murmur that get increased during expiration, these are the two murmurs. Okay, these are all some of the murmur types and all. You can read it and memorize it. It's a bit more in detailed. Okay. Again, so one tricuspid murmur is not that important, Faizan, but if you really want to know, tricuspid murmur is, so you can see that tricuspid regurgitation is holosystolic murmur. Okay. Whereas aortic regurgitation is a diastolic murmur. So type of the murmur also is helpful. You're not just looking at the site of the murmur, you're also looking at the type of the murmur. It is always difficult to remember. There is no easy way to memorize this. Unfortunately, you have to make your own way to remember it. So, but at least this helps a lot, I guess. The only murmur management that can come in exam is aortic stenosis management. So this RACGP guideline can be really helpful. And I want all of you to read this as well, if you can. So this is the RACGP guideline, and it's the up-to-date guideline. You can see the 2024. So always read the updated guidelines. There is so many guidelines there, but the updated ones. So you don't read something which shows 2020, like 2000, 20 years ago. So that's definitely has been changed over the time. So aortic stenosis is one of the most commonly encountered valvular pathology, especially in older patients. So it is very, very common. Now, not every aortic stenosis murmur is symptomatic. Most of the time, it is asymptomatic. Again, if we want to confirm the diagnosis of valvular heart disease, the only way to confirm it is echocardiogram. So aortic stenosis means narrowing of the aortic valve. If it is narrowed, then the heart cannot send all the blood into the aorta, right? And that's the time patients with aortic stenosis, their main presentation or symptoms will be chest pain or chest tightness. They will have shortness of breath on exertion, and they will have pre-syncope or dizziness. So that's our main three presentation. So this is where all the systolic murmur, so you can see aortic stenosis is an ejection systolic murmur radiating to the neck. And one of you asked about hand grip. So you can see that this is the murmur which becomes soft on hand grip. Okay, so you can read it from here. And Then there is hypertrophic cardiomyopathy. We'll talk about it later on. Mitral regurgitation, that's a pansystolic murmur, radiates to the axilla, hand grip makes it louder. Tricuspid regurgitation, it's a pansystolic murmur, it increases with inspiration. So this is a very good chart and questions come from this chart. So please memorize this chart fully. It's going to help in the exam. Now, based on the echocardiogram, we divide aortic stenosis into 4 different types. So high gradient aortic stenosis, which is the one which needs surgery. And what is high gradient AS? Now that is a echocardiogram language. So you don't need to measure any of those. So echocardiogram will say this: mean gradient more than 40, peak velocity more than 4. Mainly look at this one. If the valve area less than 1 centimeter, that is the time it usually requires surgery. Okay, so surgical repair, this is the indication. Then there are a few others which you really don't need to know. Most of the time it's asymptomatic. If it is asymptomatic, we really don't do anything. Remember, it is recommended that asymptomatic patient, even with severe AS, can go for watchful waiting. So even if it is severe AS, we don't need to treat them unless they're symptomatic. So symptoms matters most. Now, if it is a symptomatic patient who has severe high gradient AS, that's the patient who goes for aortic valve replacement. Aortic valve replacement can be done transcatheter or surgical valve prosthesis. Most of the time nowadays, we go for the TAVI. TAVI is very, very commonly done nowadays for aortic stenosis for any group of patient. Okay, so TAVI is the transcatheter one. So transcatheter aortic valve implantation. So that is a minimally invasive medical procedure and it doesn't need any open heart surgery. So they just made a small cut in the groin, go into the femoral artery, and then a catheter which is carrying the valve will be taken into the heart and then sit on the heart. It's good. If you have seen the video of TAVI, it's really, really amazing how they do it. So, but basically it's a transcatheter, minimally invasive procedure to replace the aortic valve. Okay. If you want, you can also know a little bit more about the heart murmurs from Med Bullets. So I've given some of the links here. So we'll take a 10-minute break now because I'm sure your brain is exploding at the moment. Have some tea or coffee and we'll be back after 10 minutes, guys. Shara Rahman, yes, it's all need to remember. I'm afraid anything I discuss, all needs to remember. I normally will not discuss anything which is not important for exam. Okay, 10-minute break, guys. Thank you. Okay, everyone, let's continue. So how are you guys going so far? Are you enjoying the session? Good. So now we're going into cardiomyopathy. Cardiomyopathy, not super important for exam, and it's not very difficult anymore because now you have understood the basic of it. So cardiomyopathy means the muscle of the heart is having some kind of problem. That's why we call it myopathy. So we have three different kind of myopathy. The first one is dilated cardiomyopathy. In dilated cardiomyopathy, the cardiac muscle becomes dilated or it loses its contractility. So if heart cannot contract properly, what kind of heart failure this patient will have? Guys? Yes, systolic heart failure or heart failure with reduced ejection fraction. So dilated cardiomyopathy patient, the main symptoms will be features of systolic dysfunction or features of systolic heart failure. The most common cause is unknown, which is the fancy name is idiopathic. So most of the time we don't know why it happens. And then the other causes could be alcohol, could be myocardial infarction can be a cause as well, myocarditis, some of the toxins, okay? So basically, this is a patient where the heart becomes dilated like this and it loses its contractility, giving systolic heart failure symptoms. And the treatment will be same like systolic heart failure. So all the medications that you have used for systolic heart failure, you will start in this patient as well. And you remember that if it is a dilated cardiomyopathy and their ejection fraction is less than 35, they are the candidate of ICD. ICD doesn't come in exam a lot, but this one, the HOCM or hypertrophic obstructive cardiomyopathy, very important for exam. A lot of questions come. So in HOCM, what happens is that you can see that this is the normal heart and that's the interventricular septum. And look at this one. So the, the left ventricle and the interventricular septums become hypertrophied in this case. And when it is hypertrophied, you can see there is not much of a space left in the left ventricle for blood to come here. So if there is not much of a space, what kind of heart failure we will call it? Yes, diastolic heart failure. So this patient will have diastolic heart failure because there is not much of a space here for the blood to come here so that we can push the blood out. So lack of compliance, right? So you can see that heart muscle is so strong in here. So, and then there is tiny amount of blood coming. So the systole will be striking. So in these patients, ejection fraction or cardiac output becomes even more than normal. So you can see here that some of these patients, ejection fraction can be more than 60%, even 60 to 90%. So ejection fractions are often 80 to 90%. Okay, because one, there is lack of blood here, and the cardiac muscle is hypertrophied, so it's quite strong. So HOCM, more than 60% cases, it's hereditary and it is autosomal dominant. So it can happen to either boys or girls. The hallmark of the disease is unexplained myocardial hypertrophy, especially interventricular septums become hypertrophied. The symptoms are similar like heart failure. So these patients will have all the diastolic heart failure symptoms. And other than that, you will find out that the heart will be hypercontractile. The systole will occur with a striking rapidity. Ejection fraction will be more than normal. And the symptoms, dyspnea, presyncope, so same symptoms like heart failure. So family history of sudden cardiac death in a young age can be a clue to think of HOCM. So many times in the exam question, they can give you this clue that patient have sudden cardiac death in earliest stage, especially in the family. Okay. You can also get a murmur, which is a systolic murmur. If you remember what we have shown you here, so it's pretty important to know this murmur. So HOCM gives us late systolic murmur along the left lower sternal border and pansystolic murmur due to associated mitral regurgitation. So this HOCM can give us two murmur, late systolic murmur and a pansystolic murmur. And one of the other thing we can see here is sharp, jerky carotid pulse. Okay, so remember this murmur in this patient, at least the late systolic murmur, it's pretty important to know. Now, once you think, so you'll find out a patient will come to you. So HOCM usually presents like that. Young patient went for maybe some kind of sports, maybe football, cricket, and suddenly he lost his consciousness. And then he was unconscious for a few minutes, and then he regained consciousness, and he was completely fine after that. That is called cardiac syncope. Cardiac syncope happens without any warning sign, and patient usually regain consciousness without any confusion afterwards. So that's one of the presentation of this HOCM, and also there will be a family history of sudden cardiac death. That is the time you will think of HOCM. If you think of HOCM, the investigations come in exam a lot. So first investigation is ECG. Because the left ventricle is hypertrophied, you can get left ventricular hypertrophy in this patient. And if you want to confirm the diagnosis, then we do the echocardiogram. Sometimes in resting echocardiogram, you might not be able to find out HOCM. So if you are suspicious of HOCM and resting echo did not give you the right diagnosis, then the next step would be to go for a stress echocardiogram. Okay? Even better than a stress echo, we can do cardiac MRI. That can be really good for this. Now, we know that it is a diastolic heart failure. So for diastolic heart failure, our treatment is beta blocker or calcium channel blocker, right? So that will be the treatment in this case also. Clear, everyone? Yes, this is softer with hand grip, louder with Valsalva, right? Restrictive cardiomyopathy. Restrictive cardiomyopathy is not that common. It's very severe. That is the only way to confirm. There is no way. It's not always that patient will have syncope. We will have like definitely we will see some of the changes in the echo, and in that case, it's not like these are monitored echocardiogram. So you can ask that we even do a stress echocardiogram in a patient who might have angina, right? So does it cause any problem? Does it induce heart attack in that patient? No, but we still do it. But there is always a risk. So same happens with HOCM. These are monitored. So a cardiologist is there with the patient. And we can always check the echocardiogram, the changes. And definitely we will not put him in that kind of stress that there will be a complete block of cardiac output. Okay? So it's not like we can't do it. Definitely we can do it. And that is one of the way to confirm this diagnosis, because sometimes what happens that without a stress, we will not be able to find out the cardiomyopathy. Restrictive cardiomyopathy is the least common cause of cardiac myopathy. What happens in restrictive cardiomyopathy, the ventricular wall become rigid. So the walls of the ventricle becomes stiff and rigid in these patients. And when it is stiff, one, that it cannot pump enough blood and it cannot relax as well. So this is the patient who gets both systolic and diastolic heart failure because the ventricular wall is rigid or stiff. Okay, so they get all the heart failure symptoms. There is no good treatment for it because it's like messy, and the only way to really treat this patient is heart transplantation. Right? All good? Any questions so far with the cardiomyopathies? Syncope means that patient with HOCM, they get cardiac syncope, which means they will have sudden loss of consciousness. And then when they regain consciousness, there will be no confusion afterwards. So they get sudden syncope and then they regain consciousness without any further issues. So you can see that pathophysiology for restrictive, initially because it is rigid and non-compliant, the initial thing is ventricular filling defect will be the first presentation. Okay, so initially you might find out the preserved heart failure and gradually the systolic performance starts to also get reduced. Then you get reduced reduced ejection fraction in this patient. Next, pericardial disease. So we know that acute pericarditis comes in exam a lot. Acute pericarditis means we know that the outer layer of the heart is the pericardium, and the inflammation of the pericardium is what we call acute pericarditis. Acute pericarditis, the presentation, we talked about that in our chest pain class, that patient comes to you with sudden onset of sharp, knife-like, stabbing kind of chest pain. And the pain gets worse with inspiration. It gets worse with lying down, but gets better with leaning forward, right? There might be history of recent viral infection as well. So these are the common causes. So infections, especially virus, it can be due to some connective tissue disorders, all of it. And we know that they can have pericardial rub. If you do ECG, you can get widespread ST segment elevation. We also talked about the treatment, which is the colchicine plus anti-inflammatories, right? Going to pericardial effusion. Pericardial effusion means that due to some reason, could be traumatic, could be inflammation, if there is accumulation of excess fluid in the pericardial space. So if this is the heart and that's the pericardium, normally there should not have any kind of fluid in there. But when there is excessive fluid accumulation in this pericardial space, then it can start compressing the heart. Okay, so that's what we call pericardial effusion. The problem is not pericardial effusion, but rather cardiac tamponade. It is a life-threatening condition where pericardial effusion has developed so rapidly, or it has become so large that now it is compressing the heart. So most of the patient with tamponade will come with dyspnea, fatigue, and orthopnea. So kind of features of heart failure. We can also get pulsus paradoxus, which is decrease of systolic blood pressure with normal inspiration. Neck vein can be distended. And one of the things we find in this patient is called muffled or decreased heart sound. That is commonly known as Beck's triad. Beck's triad is hypotension, distended neck veins, so raised JVP, and muffled heart sound. Many times cardiac tamponade happens after a very bad motor vehicle accident. So you'll find out that when you try to auscultate the heart, you can't actually hear the heart sound that better. So muffled heart sound. Patient is hypotensive and there is distended neck veins. Why distended neck veins? Because if this is the heart and there is a huge amount of fluid collection around the heart is not able to relax. If it's not able to relax, it cannot take blood inside. So blood is not able to go into the heart. That's why there will be raised JVP. Okay? So if we get a patient with cardiac tamponade, this has to be, so you can confirm it with bedside echocardiogram, and then the treatment is pericardiocentesis. So there is a large bore needle and you just aspirate all the fluid out of it. That's the treatment, pericardiocentesis. Okay? Cool. Constrictive pericarditis, not that important. So we move on to hypertension chapter, which is important for your exam. Do you guys have any questions so far? Hypotension, raised JVP, muffled heart sound. That's Beck's triad. Okay, let's talk about hypertension. Hypertension, although it might feel like it's the easiest topic, but it is not easy. It is really, really confusing. There's so many things to learn, and that is where a lot of candidates get wrong answer in the exam. So let's discuss hypertension, and you'll tell me that it is really complicated. So what is hypertension? High blood pressure. Normal blood pressure can be up to, systolic can be up to 139. That's called high normal, and up to 89 diastolic. So we say that normal blood pressure means it is below 140 over 90. That's the standard in Australia. Grade 1 hypertension or mild hypertension is when systolic is between 140 to 159 and diastolic 90 to 99. Grade 2, 160 to 179 and 100 to 109 diastolic. Anything more than 180 or diastolic more than 110, that's severe. Very important to know that, because severe means urgent treatment. It is recommended that for every adult more than 18 should have their blood pressure checked at least every 2 yearly. Causes of hypertension. Most of the time, we don't know the cause, and that's what we call essential hypertension. 90 to 95% cases, there is no cause. Between 5 to 10%, there are some causes, which is the secondary hypertension. So we have got kidney-related causes such as glomerulonephritis, renal artery stenosis, important to rule out. Endocrine causes such as primary aldosteronism, which is Conn's syndrome, Cushing syndrome, pheochromocytoma, some medications, like if a patient is on oral contraceptive, steroids, that NSAIDs, this can cause high blood pressure. And then coarctation of aorta as well. Okay, so these are our secondary causes of hypertension. So if we get a patient with resistant hypertension, like we are trying multiple medication, it's still the blood pressure is not coming down, that is the time we look for any secondary hypertension. So these are the signs and symptoms that we look for in that patient. If there is abdominal or renal bruit, we think of renal artery stenosis. If there is bilateral kidney masses, we think of polycystic kidney disease. So we'll talk about all of these one by one, don't worry. You can give it a read of this one as well. Let's talk about detection of high blood pressure. Remember one thing, that we cannot make a diagnosis of hypertension on a single visit. So someone came to you and you found that his or her blood pressure is high. On a single visit, you cannot make the diagnosis. The initial raised BP should be confirmed on at least 2 other visits within a space of 3 months. And if you find out that yes, as an average on 3 readings, the blood pressure is more than 140/90, that is the time you can call it hypertension. All right? So single visit is not enough to make a diagnosis. You have to see the patient 2 more times, and as an average, if it is more than 140/90, that's hypertension. Now, a lot of things to remember. You can just read this, that what are the actions and all. I'm going to go with therapeutic guideline for this one because you really need to know that. So when we talk about treating a hypertensive patient, not every patient who has high blood pressure will need treatment. That is the first thing you should know, because we have that thinking that anyone who has high blood pressure, we will need to give them blood pressure medication. It's not like that. So when we start blood pressure treatment, to start blood pressure treatment, we follow this ASCVD risk assessment chart. So what's that? So AS is atherosclerotic cardiovascular disease risk estimator. So we have a OST risk calculator, and with that risk calculator, we can decide who is high risk of having a cardiovascular complication in the next 5 years. So that's risk assessment is important. So any patient who we think that we want to start medication, and because the blood pressure is high, we need to assess their risk first. So that's the ASCVD, which is basically the OST risk calculator, or which is basically the cardiovascular risk estimator. Now, cardiovascular risk estimator, we will show you what does it mean. It gives us that who is high risk, who is intermediate risk, and who has low risk of cardiovascular complication in the next 5 years. Okay. Now, before we go into that, there is a chart that I want to show you. So this is the thing. So the risk estimator, see that someone who has got confirmed hypertension, all hypertensive patient should start lifestyle modification. That's the first line treatment. Along with that, we do the 5-year absolute cardiovascular risk assessment. This 5-year risk assessment, if the risk shows patient has between 0 to 5% risk, they are called low risk. 5 to 10% risk, they are called moderate risk. And 10 to 15% called high risk group. So now you know who are low risk, moderate risk, and high risk. Okay? Now have a look. For patient who has established cardiovascular disease, someone who already got a heart attack, a stroke, who has peripheral vascular disease, they have established cardiovascular disease. For them, any kind of hypertension should be treated. So we want to keep it lower than 140/90. And usually best treatment to start with will be ACE inhibitor or ARB for this group. For patient with high risk, which is that group of 10 to 15% risk, we will start treatment. So they will be also we will start treatment right away along with lifestyle modification. For patient with intermediate risk, so 5 to 10%, That group also we will consider starting blood pressure lowering treatment along with lifestyle modification. This is where we can delay. If patient wants to just wait 3 to 6 months, try their lifestyle modification, we still can allow that. We can say, yes, you can definitely do that, but just for 3 to 6 months. And if it doesn't go down, I believe you should start treatment. But for high risk, absolute recommendation will be to start treatment. For low risk, we do not need to start treatment right away. We can wait even 6 to 12 months. We will advise the patient to go for lifestyle modification and see if we can bring down the blood pressure in that way. Does it make sense, guys? Is it difficult? Is it a bit difficult? Very clear for everyone? Good. All right. So one of the other things sometimes will come in exam is 24-hour ambulatory blood pressure monitor. 24-hour ambulatory blood pressure monitor is needed if you find that someone having discrepancy between different blood pressure reading. You're finding that when the patient is at home, blood pressure is normal, but when he comes to your clinic, blood pressure goes high. So there is discrepancy. Or different times, sometimes patient's blood pressure is very high, sometimes it's low. So it's all over the place. When there is discrepancy between blood pressure readings and you can't be fully sure whether it is hypertension or not, then you use this 24-hour ambulatory blood pressure monitor, where you put a device on the patient's arm, and that device will check the blood pressure throughout the day, and then it gives an average blood pressure. Okay, so that's one of the way that we can confirm whether this patient has got hypertension. The most common curable cause of secondary hypertension is primary aldosteronism. Remember that? Non-drug treatment. So every patient who has high blood pressure, lifestyle modification is must. So regular aerobic exercise, reduce alcohol, moderate salt restriction, healthy eating, and weight reduction. So normal, healthy, balanced lifestyle is the first-line treatment for any kind of hypertension. Then if we need to start treatment, especially for high-risk group, established cardiovascular group, or moderate risk group, this group, we will treat them. So the treatment, we can choose any of these four. We can choose either ACE inhibitor, ARBs, calcium channel blockers, or thiazide diuretics. None of them are first line. Any of them can be first line. But the choice of your treatment should be influenced by the patient's other comorbidities. Like someone who has got heart failure with reduced ejection fraction and they have hypertension, you will definitely choose ACE inhibitor that will treat hypertension, that will treat heart failure. So you always think about the comorbidities when you are choosing the right blood pressure medication. So how to start a treatment for blood pressure? So one way is we can start a single drug, just one drug at a time, or we can do low dose of 2 drugs as a combination. Now, let's say you started a single drug. Let's say you started one ACE inhibitor in a low dose. So to allow the time for optimal benefits, changes to drug therapy should be considered 4 to 6 weeks after starting the treatment. So do not think that immediately after giving a medication, the blood pressure will suddenly drop. The medication that you have started, it can take 4 to 6 weeks to give its maximum benefit. So let's say you started a low dose ACE inhibitor, and patient came after a week and saying that, oh, what have you given to me? It's not working. Will you just increase the dose of the medication immediately? No. Unless it is really high, you can, really high means 180 systolic and 110 diastolic. Unless it is really high, you really don't need to increase the dose until 4 to 6 weeks mark. See how much maximum benefit we can achieve with this dose. And again, after 4 weeks, if it is not coming down, then you can increase the dose. Make sense? So you can choose any of those. So go through the ACE inhibitor, ARBs, the calcium channel blocker, commonly amlodipine and larcanadipine is used in Australia. Thiazide diuretics like hydrochlorothiazide and indapamide, that's normally what we use. So these are our first line antihypertensive, ACE inhibitor, ARBs, calcium channel or thiazides. The second line is we have got potassium sparing diuretics, which is your spironolactone or amiloride. Then we have got beta blockers, then alpha blockers such as prazosin. Even we have got non-dihydropyridine calcium channel blocker, diltiazem verapamil. We have centrally acting one like methyl dopa, moxonidine, clonidine, or even minoxidil. So these are rarely used. So I would like you to at least remember some of the second line like spironolactone, beta blockers, and prazosin. That's commonly what we would use as a like fourth, fifth, sixth line. All right. Are you guys okay so far? Did you understand what we are going to do in case of hypertension? So mainly start. So one option is start a single drug or start a combination of two drugs. And then assess them every 4 to 6 weeks and then change the medication. If you started single drug and after 4 to 6 weeks there is no improvement of blood pressure, then you can use a combination. So let's say you started ACE inhibitor, low dose at that time, and then you can add a calcium channel blocker at that time or thiazides. Instead of increasing the dose of the single drug, it's always better to use two different group of antihypertensive. And then let's say after 4 to 6 weeks, still blood pressure is not well controlled, then you can start increasing the dose of one of them at a time. Age itself is not a factor to choose the right antihypertensive. It's the comorbidities of the patient which we should consider. There are some important topics related to blood pressure, which is the severely elevated blood pressure. So patients can come to you with three different kind of emergency related to hypertension. One is what we call severely elevated blood pressure without any symptom, hypertensive urgency, hypertensive emergency. You should know this. So severely elevated blood pressure without any symptom means blood pressure more than 180 over 110, but they don't have any symptoms like no headache, no dizziness, no end organ dysfunction or damage. End organ dysfunction means retinopathy due to hypertension, kidney failure, those kind of things. So these patients is not like they don't have immediate threat to life. So our goal will be to reduce the blood pressure within 1 to 2 days to a safe level. So we don't need to bring it down to 140/90. Just we want to bring it below 180 over 110. Okay? Hypertensive urgency. Blood pressure is high, but they have symptoms. But they don't have any end organ damage. These patients, we want to reduce the blood pressure within hours, which means, again, the same thing. We want to bring it below 180 over 110, but not within days, within hours. And they usually get admitted to hospital. Hypertensive emergency is the worst, where blood pressure can go more than 220 over 140. They have symptoms and they have end organ damage. And this is an immediate threat to life. Blood pressure needs to come down within minutes. Okay? So understand the difference between these three and how severe are they. In case of patient with severely elevated blood pressure without any symptom, normally there's a lot to know from here, but we say that if the patient was not getting treatment for hypertension before, in this group of patients, before starting the treatment, allow a period of observation with repeated measurement to see if the blood pressure settles without any intervention. Sometimes the blood pressure can go high if the patient is stressed, anxious about anything. So for this group of patient, before we start any treatment, we can just observe the patient for even half an hour and repeat the blood pressure and see if it's coming down. If it doesn't come down, then we start antihypertensive medication, which is usually the calcium channel blocker like amlodipine in this patient, and send the patient back to their GP or any other doctor so that it can be gradually checked and monitored. Whereas hypertensive emergency, the same thing in here, we would like to reduce it within hours. There is no need of waiting in here. We would start the patient with amlodipine if the patient was not taking any medication before. Hypertensive emergency needs to be treated immediately and usually it goes into ICU, and their treatment will be IV antihypertensive like IV hydrolagin, clonidine, or metoprolol IV. All right. So this doesn't come in exam in a great deal. So I just want you to understand that how we manage these things and what are the way to differentiate between these three things. Okay. Did you guys get an idea? You don't need to go through all of this. It's a specialist level, but if you have understood the basic, I'm okay with that. Okay. This is from the notes. So these are the guidelines for ambulatory blood pressure. So you can go through that. Non-pharmacological strategies, we already know. The most important is weight reduction. We say that 1 kilo weight loss can reduce the blood pressure by 2.5 systolic, which is pretty good. This one. I wanted to show you the cardiovascular risk assessment. It's quite colorful and it's important. It comes in exam. So we follow this guideline from the Australian risk chart. Let's have a look. So what do you see on this chart? So on the left-hand side, this is the group of, this is women, and on the right-hand side is men. And we can see there is a smoker, non-smoker, same here, smoker, non-smoker. We can also see the age group here. And on the y-axis, we can see the systolic blood pressure, such as 120, 140, like that. And on the x-axis, we can see the cholesterol HDL ratio, which is this 4, 5, 6, 7, 8, right? So these are the main contents of it, and there are different colors. So first of all, they will give you a question. 64-year-old smoker women, blood pressure 135/68, cholesterol HDL ratio 6.6/1. What is the patient's 5-yearly risk? That's one of the questions, very important. Now, it's a 64-year-old, so we know that this is 64-year-old group. This is the women and a smoker. So we are looking into this box. So first, identify the box that you want to look at. Then we need the blood pressure and cholesterol ratio. So blood pressure in this patient is 135. We only need systolic. So 135 is systolic. Now, this is where it's important to understand this. So you can see here, this is written 120, but this box, the maximum systolic blood pressure we will put here is up to 130. Or we say up to 129. Let's say 129. Same in this box, up to 149, 169, okay, like this, 189. So even though it's 120 in here, up to 129 systolic blood pressure will fall in this group. Now tell me 135, which box it will be? We are in this box. So is it up to 129 is in this box? Up to 149 is in this box. So that means we're looking into this second box. Yeah, okay. Now, after that, we have cholesterol HDL ratio 6.6 over 1. So we're looking at 6.6. So we have got, in here, you can see this box. Although it is written 4, this box is up to 4.5. This box is up to 5.5. This box 6.5, 7.5, 8.5. Right? So we have got our patient 6.6. So we need to know that up to 6.5 is in this box. So 6.6 will go in here. So if we go up, so that's where we have the yellow box, right? So we have got the yellow box in this patient. Did you guys get it, how we came into the yellow box? There is no reason of why, it's just how the chart it is. Okay, now every color has some specific risk. So if we go into this, let's see if this works still now. So every color has some risk. So you can see the yellow is in the high risk group. So in exam, they will give you that. So yellow means patient has 16 to 19% risk of having a heart condition. All right. So this is how you will be able to find out that what is the risk of this patient. So they will give you this chart, and then the options will be high risk, moderate risk, or they can give you the percentage, 16 to 19%, 30%. And it's easy to find out when you know how to get into the right answer. Clear, everyone, with this chart? Yes, people with diabetes will have different chart. So remember, for blood pressure medication, you can always choose from any of those ACE inhibitors, calcium channel, or thiazide diuretics. And you can add on as you want. This is a good table to remember. So some of the coexistent condition, like in a patient who has asthma, COPD, we try not to use beta blocker as our first line blood pressure medication, because beta blocker can make it worse. Same in a patient with heart block, we try to avoid beta blocker, calcium channel blocker. In patient with diabetes, we try to avoid thiazide diuretics because thiazides can increase blood sugar. Same with the hyperuricemia or gout, we avoid thiazides if we can. Peripheral vascular disease. Again, we don't want to give something which can aggravate the problem, like beta blocker, which can cause vasoconstriction. Rather, if we give something vasodilator, like calcium channel blocker, it will work in both ways. Renal artery stenosis. If it is a single renal artery stenosis, then the best medication will be ACE inhibitor or ARBs. If it is bilateral renal artery stenosis, then we avoid the ACE inhibitors. The best would be calcium channel blocker in that case. All right, that's all about cardiology that we are going to discuss in these free 2-week sessions. We will still have one more sessions for cardiology with the course student, which is mainly about all those SVT, atrial fibrillations, all the arrhythmias, which is the palpitation chapter, together with ECG. Okay. I hope you guys are enjoying the sessions. If you guys have any questions, please ask me. So if you are not in our Facebook group, so this is our Facebook group where you can get updates about all the things. You know that your 2 weeks free sessions are going on like this. You had your yesterday's session, today's session. 24th of August, there will be uh, Akshita, very, very good. You will love her class. So she's going to take the second random question solve class with you. And we'll finish this 2 weeks free session with the cardiology question solve on 25th of August. Okay. So the chapter number we have mentioned in the first class, Fatima. So there is not much in John Mortag, especially about this. So hypertension, let me go to our first class. So there is nothing like, uh, the valvular heart disease that we have shown you today, there is nothing in John Mortag about it. Then about, let's see the hypertension chapter. So we have got chapter 76, which is hypertension in John Mortag 9th edition, and 75 is the heart failure chapter. Okay. Any other questions? So emergency, hypertensive emergency, what's the first line treatment for that? So the first line will be any of those, hydralazine, clonidine, or metoprolol. So we'll go with hydralazine because that's the first in therapeutic guidelines. So we'll choose that one. Yes, valvular heart disease from the notes and from RSCGP. Yes, the recordings will be uploaded by tomorrow. 25th is not the last date for enrolling for the course. So you can enroll at any time, but again, we will start the course immediately. It's a good idea that by now you should already understand how we take the sessions. If you feel that, yes, this is something that's going to help you, or it is useful, then yes, I would suggest that during the next 1 week, finish your admission so that you can just catch up quite easily. The Studies class that was not on Facebook, so we will upload that in the portal. Labetalol can be used for pregnancy. Nitroglycerin can be used also. So a lot of things can be used. Labetalol, nitroglycerin, beta blocker, nitroprusside. So no, the topics that we cover in the class is more than enough. So the theory classes and the random questions that you get, in both classes, you get to know most of the topics, and that is more than enough to pass this exam. The drug that is mentioned first in the guideline, usually it is the first to start with, unless patient has any contraindication. All right, guys, that's it for tonight. I hope you are enjoying the sessions, you are learning, and we still have 2 more sessions to go with. If you have any questions, any queries, you can always reach us through email. You can always reach me directly through the messenger. Okay, so we're always there to help you. Thanks, everyone. Yeah, so theory definitely will try my best to finish it by mid-November. But again, the course will run till December end. So we'll still continue doing some question solves, but theory, I will finish it before. Yeah. Thanks, everyone. Have a good night. Bye.